Well, good morning. Here we are at another teleconference. These are an effective way to try to get more information from the public. We've reviewed a number of pieces of information today. It's going to be long-term care insurance. Just to buy a little time in case anybody else is coming on. Today, both the House and Senate will be in session on the floor. We're going to practice social distancing, and actually we worked out an agreement on workers' compensation to make sure that people that are on the front line, including the nurses in nursing homes, police, fire department, first responders, they all will be presumed to be working while they got COVID-19 if they get that. So we'll make sure that they were covered. It will be bipartisan. It wouldn't surprise me if we have 100% support for the folks that are on the front line. So any of those that are listening, thank you for your work there. Today, we're going to look at the impact of COVID-19 on long-term care, on the long-term care community. We know that residents of congregate living facilities like nursing homes and assisted living facilities are obviously among the highest risk. We're also especially concerned about this, and this is something we hear often from our constituents, concerns for their loved ones who live and work in long-term care facilities. One issue we heard about from the concerned families was the lack of any information about the facilities and which ones had COVID-19 cases. I appreciate Senator Housley and Senator Benson that they sent a letter to the commissioner last week expressing their concerns, and I'm glad to say that the department is now disclosing that information. This continues to be a bipartisan effort, especially when it comes to protecting seniors in facilities. And with that, I want to turn this over to Senator Housley to moderate this discussion time.
Thank you so much, Senator Gazelka and members of the working group, for allowing me to moderate this today's discussion on long-term care and the impact COVID-19 has had on the industry and Minnesota seniors and their families. Today, we're going to hear two presentations. First, we're going to hear from the long-term care imperative. That's the care providers and leading age. And then we're going to have our state ombudsman, Cheryl Hanna, do a presentation. And then we're going to hear briefly from Chris Erzman, the Director of Infectious Diseases at the Minnesota Department of Health. Before we start the presentation, I do want to draw attention to the written testimony that we received ahead of today's hearing. We've received testimony from James Weston, UFCW Local 1189, and we've also received a copy of an April 1st letter from several consumer advocacy groups that was sent to Commissioner Jan Malcolm. I want to thank the Commissioner also for releasing the names of the providers and the facilities that have contracted a case of COVID-19. I really appreciate when Senator Benson and I sent that letter. She listened. She's been doing a great job. I encourage the members to take time to read over those documents. So we have three testifiers here ready to represent the long-term care imperative. First, we're going to have Deb Barnes, the Executive Director for Lakeview Methodist Healthcare. Then we're going to have Carrie Thurlow, Leading Age Minnesota, and then Toby Pearson from the Care Providers. Members, please remember to raise your hand on Zoom if you have any questions. I've got my other laptop going here so I can watch the Zoom if you raise your hand. So if you have a question, I'll make sure to call on. Staff from the Minnesota Department of Health's Health Regulation Division will also be available for questions after the long-term care imperatives presentation. We're going to start with Ms. Barnes, and when she's finished speaking, we'll go to members for questions before moving on to Mr. Pearson and Ms. Thurlow. Ms. Barnes, go ahead and begin when you're ready.
Okay, thank you very much. Good morning, everyone. Thank you for wanting to have a little peek of what it's like in the field in this ever-changing new normal. Can you hear me?
Yep.
Okay, very good. So Fairmont, just by way of introduction, is a campus of a skilled care center, an assisted living, an independent building, and a child care center. So when, of course, this all started, I'll just kind of take you through what we've been through and what it looks like here. So all of our doors, of course, are locked. There's one door open on the campus, not open to any visitors or families, only open to staff. At that door, they get their temperature taken every day. Actually, if they leave for a noon meal or such, they come back, they take their temp again.
Hey, Dad,
Yes.
can I just interrupt you for 1 second?
Yes.
Can you turn your video button on, or do you not have video capability? Because we can't see you.
Well, I thought I was on. Let's see.
Lower right camera with the red line.
All right, let's see. I don't think I have it.
No? Lower left. Are you on a laptop or an iPad or a phone?
Laptop.
Okay, your lower left corner.
Okay. And I don't have it.
All right, continue then,
sorry.
Deb. That's all right, we'll keep going.
I'm sorry. All right. So we have 165 staff. So as I said, all of those staff come through one door with their temps taken and getting their masks. The first thing that we did was create an isolation wing, expecting possible cases, and a wing for new admissions to come for 14 days, even if they had tested or if they had not been tested. So our first order of business was to move 7 residents to create an isolation wing. Then we had to quickly, because we have childcare here, we had to quickly install a new door from the outside directly into the childcare center so that those parents and kids did not enter the nursing home. We had to restructure our dietary processes to go to room delivery and our housekeeping processes to double their daily routine. Of course, all of this extra work as staff are out because of symptoms or exposure or because of a compromised health condition. So at this point, we have had 19 of our staff of 165 out at some time or another. So with all of this extra work, with everything else going on, we have 19 people out. I called the workforce center frantically saying, are there any people that are now out of work that are interested in learning about healthcare and coming? They did have 6 people interested. 3 of those did come to us. So we were able to incorporate those 3 into our dietary and our housekeeping departments to help lift the load for those departments. We had 3 people who had finished their nursing assistant class, but had not tested yet because the test outs were now canceled. So ordinarily, we would have had to have those people discontinue working, and we had already because there was no test out, but we were seeing we had to do something drastic. Even if it had been working outside the law, we had not enough people. So we were so thankful, so very thankful when CMS waived that 4-month rule so that we could bring these people back even though they hadn't tested. We could bring them back and put them on the floor, and they are now working full time. So that was truly a godsend. The Families First Act has been another godsend because, as I said, these 19 people and that number is increasing. We're now able to pay for them to have up to 80 hours out if they have symptoms or if they were exposed. So that's another wonderful, wonderful thing that the federal government did. State government, DHS, jumping so quickly into action to allow us payment upfront for extra expenses is huge. Another thing, MDH actually is calling us now just to check in, just to see how are we doing, what can we do. Those things have been so meaningful, and they tell us that you're right there with us, and you're not going to leave us without the help that we need. So that's kind of a quick update. Of course, this has all caused great agony for residents. I think of myself at home not being able to go out and Then I think of residents who are in their rooms, and these are basically bedrooms, can't come out of their room unless they have a mask on. We're trying to do everything possible with virtual activities, with setting up Skype with their families, everything we possibly can do, but it's a much different kind of life for them. And it is an agonizing time. And so our activities department, our social workers are concentrating and doing everything they can to uplift residents daily. There's a lot been, let me just add one thing, there's a lot been said about personal protective equipment. That is also a concern here. We have enough masks now for our staff for about the next 25 days. We only have 20 masks with shields. So when we have someone, we've had no one in the building yet that's tested positive, but we have tested people. So the masks with shields go to only the people that are taking care of the people that have been tested. So we're down to now about 20 of those left. And we do have one box of N95s that are outdated, but we're saving those for an actual case. So that's a bit of an update from the field. Are there any questions you have? Again, thank you to all of you, to DHS for reacting so quickly with extra payments, for MDH for calling us and checking in. That means the world to us.
Thank you. Thank you so much, Ms. Barnes, for taking time and being with us and for everything that you are doing. Take care of yourself. We've got a question from Senator Julie Rosen.
Well, thank you, Senator Housley. Hi, Deb. Deb Barnes
Hi.
is my constituent, my friend. She's done a great job. She's been through that whole long-term care industry and knows it in and out. And so she's my go-to whenever I need any help with long-term. And you are definitely on the front line. I know my colleagues have heard about Fairmont and Martin County, and they're up to 32 cases in that county, 3 deaths. It's definitely a hotbed in southern Minnesota. So my question to you, though, Deb, is there anything that we can continue to help you with? Is there immediately, the question is going out to our school systems, to the hospitals, but for you, is there anything that we can do right now to help you?
I think Carrie and Toby will speak more to that from both associations and others as well, with things I perhaps haven't thought of. But I forgot to say that the waving the fingerprinting, Julie, that was also a huge thing. Not having to wait for people to get fingerprinted to be able to go on the floor. Thank you for that. That helped tremendously. Again, the waiver of the 4-month rule from the federal level was huge. We're going with that. I know that there's possibly a state regulation also that deals with that. So I'm hoping that there's no state regulation that stands in the way of that federal regulation being federal waiver being continued.
And if I could, Senator Housley, I just want to wish you, Deb, and your family and all your residents and your workers to be safe and healthy. And thank you again for all you've done for your residents. Really do appreciate it. And those little ones. I think
Thank you.
This was one of the first ones to pull in childcare into their facility. And it's wonderful to watch.
It is. Yes. Thank you all.
Thank you, Senator Rosen and Deb. We have a question from Senator Pratt.
Thank you, Senator Housley, and thanks, Deb, for being on the line today. I just wanted to follow up. You were talking about your personal protective equipment, and it sounded like you had enough on hand, but can you talk about, have you had any, it seems like I'm getting emails from hospitals, clinics, care facilities that are still struggling with getting that distribution. Have you run into any issues or concerns with that? And maybe you can share some of your experience.
We certainly have had issues with getting any more. We did order when our supplier called initially and said, if you want an order, you'd better order now. And so we did. And of course, they were limited to, I believe, 60 or 70% of our last year's orders. So we did order quickly. So as I said, we have enough masks for about 25 days. We have other orders in. We have no idea when those will be coming. I know our supplier has tapped someone in South Africa. We have a relative here of somebody that works for MyPillow. So they've sent us a shipment, but those are the cloth masks, which are only 50% effective. So we have had about a box of about 50 of those. But what we have in the house, we have in the house. We haven't had any cases yet. So if we do have a case of COVID, we will go through those within probably 2 weeks. And we have on order, we have our supplier, we have another supplier. Every place we could think of, we have orders in, but we have no idea, no end date of when they'll come.
Thank you.
Thank you. Any more questions for Ms. Barnes? Okay. Thank you so much again, Ms. Barnes, for everything you're doing and keeping all of your residents safe and the kiddos too. So thank you. You're welcome. Thanks. Now we're going to move on to Mr. Pearson and Ms. Thurlow with the long-term care imperative. And I think we'll have you go first, Carrie Thurlow, if that's the order that you're okay with. Take it away, Ms. Carrie Thurlow.
So, Madam Chair, if we may, I think the presentation will flow a little bit more logically.
Okay.
If Mr. Pearson go first.
All right, that sounds good. Toby Pearson with the Care Providers of Minnesota, you're up.
Thanks, Senator. As you just heard from Deb, there's a lot going on in long-term care, and we just wanted to kind of give you a background of what we've been doing as well as some of our challenges that we're facing. As you know, as we learn more about COVID-19, we know it's a uniquely dangerous type of virus, especially targeting folks that live in senior care settings. You've seen it around the nation. You know there are challenges. We're doing our best here in Minnesota to try to prevent similar stories from happening. It's changed daily care for seniors as the threat of transmission has meant that licensed facilities, nurses, workers, volunteers, family members are all changing how they give their cares as we try to reduce the chances of the virus entering facilities like you heard from Deb Barnes. Caregivers in our facilities are working tirelessly in a difficult environment to try to adapt to the new and changing demands of this virus. As you heard, some of the controversial things that we've done has not been without pushback from some advocates. We did move quickly to initiate aggressive infection control measures and screening procedures, meaning not everybody could get in to see their loved ones when they wanted. We needed to limit visitors to only medically necessary and end-of-life circumstances. We were trying to protect the seniors as much as possible and protect the residents by working with folks and keeping the virus out of the community settings. We're aware that visitation restrictions have been difficult for seniors and their families, and understand that some of their concerns about transparency and access do need to be measured. We do also believe, though, that by working with the CDC and MDH, we are working to save lives at the same time. We've asked that all medically needed visitors wear face masks and limit their visits to specific locations, trying to make sure that we limit the places that they go so that they don't spread the virus around. We screen folks for signs and symptoms when they enter the facilities. We also direct persons within senior living environment to wash their hands, and as you have heard multiple times, do it well. Senior care leaders continue to work collaboratively with the Department of Health and other leaders to reduce direct social interaction between residents themselves and residents with community members and even with their families. So as you heard from Deb, we're trying to serve meals in singles rather than in community settings. Although it's a bit isolating, we also know that it prevents the exposure to the virus. We're using all of our knowledge to protect senior residents and caregivers as much as is reasonably possible. Not surprisingly, the challenges expressed by acute care colleagues are also challenges that we have been experiencing. We work with the Department of Health to address two of these. The biggest, as you heard from Deb, PPE, not knowing whether or not you're going to get a new or your next shipment is a big one. And then also increased testing. We know that folks that come in can be asymptomatic and we need to test. We're challenged by not being able to adequately test, but we continue to ensure as well as we can to prevent infections. Alongside other member organizations, we work to ensure communication channels amongst all stakeholders are open to help us share information and provide as much certainty as possible. We're in regular communication with the Department of Health, the Department of Human Services. We're sharing information at least 2 or 3 times a week to find understanding and solutions to the challenges that face our providers. It's included working with DHS on some of the payment things that you heard from Deb. It's been for nursing facilities as well as assisted living facilities. Also, as you heard from Deb, we included work with all of the agencies involved in background checks and TB testing and some of the other barriers that exist to our folks. We coordinate daily with the State Emergency Operations Command and regional health coalitions to accurately assess the resources, including PPE. We work with the Hospital Association and MAGIC, the Association of Geriatric Inspired Clinicians, to try to figure out how we do better for intensive care capacity and also how we do better for all of our congregate settings. Several of the things we're currently talking about include possible step-down strategies in locations so that if there are overflow needed from hospitals, we would have some facilities ready for step-down from hospitals to take COVID wings. As you heard, Deb Barnes had been working on that locally. We are also working with some of our state partners to try to identify if there's a need for an entire facility, that we would actually have an entire facility that would be able to be dedicated to COVID use for vulnerable populations. We also work with the medical community, those MDH and clinicians who operate the communities, to try to have evidence-based approaches to when we transfer and when we send folks to hospitals. We know that this can be a trying time and also a vulnerable time for those folks, so we try to make sure that it's appropriate when we do it. We try to rely on all the guidance that comes out. Sometimes we feel like we're drinking from a fire hose when you see everything coming out from CMS, CDC, our national affiliates, but we're doing the best we can to try to continue ongoing communication with everybody. We work collaboratively at least every day with both associations. We work in collaboration at least weekly with advocates to try to address some of their concerns. We have tried to communicate frequently through public channels to our members that our residents still need contact from family and friends. We've tried to set up as many possible texting, video, teleconferencing, Facebook, other social platforms for folks to stay connected. Another thing that we really tried to focus in on was our workforce. And Terry will mention more about this, but we have been coordinating with union representatives to try to create more easy over options so that if folks are getting furloughed or laid off from some of the clinic settings, that they could easily transition into our long-term care settings. Finally, we have one area that's really been specifically challenged, and that is the adult day population. Those adult day settings are very integral to seniors and their socialization. And as you know, the state has closed them down for reasons of transmission. But how we continue to support those folks as they try to provide wraparound care like daily check-ins via teleconference, meal delivery, or other activities is an important step that we'd like to see, and Ms. Thurlow will mention more about that. Although this list is not complete, I just wanted you to know that we continue to work with all of the agencies involved to try to do the best care we can for all seniors in all of our settings. And on behalf of more than 100,000 professional caregivers in Minnesota, we just really want to say we appreciate your support and patience and everything you've been doing at the Senate to try to support us. We think that the caregivers will keep working every day to make the lives of the seniors as best they can and also as safe they can. So with that, I will turn it over to Ms. Thurlow to discuss more of our needs from what we've been seeing in workforce.
Thank you so much, Toby Pearson. We're going to take questions after Ms. Thurlow does her presentation. So welcome to the working group, Carrie Thurlow from Leading Age, and go ahead.
Thank you, Senator Housley. Welcome to my home office. Thank you for the opportunity to speak today regarding the ongoing needs of senior care providers throughout the state. I think Ms. Barnes paints a pretty clear picture of what providers are dealing with throughout the state. And Mr. Pearson really explained the commitment that all of our members have to protect seniors in all of their variety of settings. I'm going to spend my time talking about 5 areas that we have identified that need further action. And I want to first cue this off by first saying thank you for all that you have done. Especially the first relief bill where we have passed additional funding relief for providers is very much appreciated. And the waivers you have passed have been helpful, as Ms. Barnes pointed out. But as this public health emergency continues, we learn more and identify additional needs. So the areas that I would like to talk about are first and foremost workforce, and then also access to personal protective equipment, that PPE that we've been hearing about, additional access to testing, funding for adult day services, and last but certainly not least, continued coordination and strategy for step-down facilities. Now, I know that's a lot, so I hope to go through that efficiently and take questions at the end. First is workforce. Minnesota's senior care providers want to do everything they can to continue to provide safe, quality care, but they are facing a staffing crisis. Usually in times of higher unemployment, that bodes well for our providers. But because so many healthcare workers have to quarantine because of exposure, because they have to stay home with their children, or quite frankly, because we've had to adjust our staffing models to accommodate new guidance like prohibiting congregate dining, that increases our staffing needs. And as Ms. Barnes indicated, the federal government has stepped in and issued a blanket waiver for many of the regulatory constraints that we have on bringing up workforce quickly. However, we do need state action to waive corresponding state regulations to those federal regulations. We have requested that the governor grant additional flexibility through executive action, or if that is not possible, we have asked the legislature to provide flexibility from those state regulations so that we can best address our workforce needs at this critical time. There are several areas where we need to do some focused waiver of state regulation. First is in the area of allowing us to redeploy and reactivate healthcare workers. We know from the news reports that there are literally thousands of healthcare workers that have been furloughed or laid off from hospitals, clinics, or other healthcare settings. These are a variety of healthcare workers, nurses, CNAs, trained medication aides that have licensed good standing with the licensing boards. And that we would ask that we waive state regulations that would require us otherwise to conduct another background check, TB testing, or other vetting. We would ask to waive those as long as they have good standing with the licensing board and were previously working in active healthcare. Also, those healthcare workers that have good current licensing but maybe weren't working in healthcare for whatever reason at this time, we would ask for similar treatment for those workers as well. Second, for healthcare workers that have expired licenses or registration, we know that the boards have expanded the renewal period, but there are some provider or healthcare workers that have expired license. We are asking to provide an expedited 24 to 48 hour process to allow nurses, TMAs, CNAs, or health aides to reactivate their licenses as quickly as possible and thus be immediately eligible for hire. And third in the workforce area is really around streamlining the training process. we are proposing, as many states have also proposed, to allow for a truncated training program that would essentially allow us to create a core of basic care aides that have done the core training of 8 hours that we could bring on to allow for direct training. Of course, these workers are supervised and assessed for competency by their supervising licensed nurse. And of course, this is a temporary situation to get us through our public health emergency. But we believe that, in addition to waiving the 4-month rule that Ms. Barnes talked about as being critical, is very important at this time so that we can bring on new healthcare workers as well. In the interest of time, I'm going to move now to the issue of personal protective equipment. I'm happy to talk and answer questions about workforce, but I also want to talk about personal protective equipment. And I think Ms. Barnes highlighted the shortage that senior care providers are facing. Our burn rate is pretty strong, even in situations where there may not be an outbreak in that facility. Our members are following the guidance that all workers in the setting be masked. Now, those aren't all with the critical N95 masks, but it is becoming increasingly difficult, and providers continue to report that access to personal protective equipment, including masks, gowns, and gloves, are of critical importance. And it is important that senior care providers, both in nursing homes and assisted living, are considered a top priority for distribution so that we can protect those that we are caring for, those that are most vulnerable to the virus, and the employees that take care of it. Third is testing. We still need to work on the expansion of testing capabilities. You heard Mr. Pearson talk about all that we are doing to prevent the spread of the virus in our settings. But the reality is that the virus can spread through asymptomatic carriers. And the only way we can identify those carriers is through more testing. And so we would ask to continue to prioritize senior care providers as well. Fourth is really to address the gaps of adult day services. As you've heard, adult day programs have closed throughout the state. And that does two things. It leaves thousands of seniors and persons with disabilities in gaps in services that they would have otherwise been receiving. And secondly, it's creating a huge strain on those programs that were already financially frail. We at Leading Age have already heard from some providers that really believe that they may never open again unless there is some financial assistance from the state to help them. We are proposing that the state take action to create payment and allow payment for virtual adult day services and supports so that clients can still have those daily check-ins through virtual means. Maybe they do meal deliveries and other essential services. Other states have taken this action, and it is proving to not only help fill the gaps for those clients, but help provide a financial bridge for those providers as well. And then last but certainly not least is the strategy for step-down settings. And this is a collaborative conversation with hospitals and regulators as well. But know that senior care providers will play an important role in helping hospitals maintain capacity during the surge by serving as discharge locations for COVID-19 patients that are improving. Current guidance is that not every senior care setting should be a discharge location, but that we should identify senior care providers to serve as step-down providers and begin to cohort populations throughout the state. We have begun these discussions, but there will be likely policy issues that will emerge in the near future, including regulatory and reimbursement issues. It should be recognized that these step-down providers will have a cohort of COVID-19 residents by design, and these settings should not be portrayed as having an outbreak or poor infection control procedures. That is a very different situation. Additional issues might arise through this emergency, and I will say will probably arise. It's more likely than not as we learn and go through this emergency. The financial ramifications to providers will be significant. Providers have experienced significant loss of Medicare revenue due to the stoppage of elective medical procedures. Admissions are down but costs are growing. Our goal has always been to ensure that seniors have access to safe, quality care options in Minnesota communities. And following this emergency, we anticipate that there will be a need to assess the financial health of the senior care network and look for ways to ensure its viability for the growing senior population going forward. Finally, thank you. The communication and collaboration with legislators, staff, state agencies has been truly remarkable. Thank you for your continued support for Minnesota's senior care providers.
Thanks so much, Ms. Thurlow. I do have one question, and then I know Senator Gazelka has a question also. Chair Gazelka, are you seeing any increase in cost in your PPE? I've heard stories from around the state that they've doubled and tripled and quadrupled.
Yes, very bluntly, absolutely, this is a growing cost. And so whatever was the traditional analysis, for example, for nursing homes on their cost reports of what would be a reasonable cost, is no longer applicable in this public health emergency. The cost for PPE are far beyond what would be in the normal course of business.
Thanks. Unfortunately, thanks. Senator Gazelka.
Sure. Yeah, thank you, Senator Housley. I actually now have two questions, one for Toby and then one for Carrie. First of all, for Toby, I've got my mother-in-law and father-in-law are in an assisted living facility. They isolated early. What are the plans related to how we get to a place where we can still visit? And are there consequences related to that? In other words, the consequences of isolation, what are the negatives of that in the path we're on? And then for Carrie, I wrote down your notes about how we can get more people as far as for the workforce, making sure we have people there. Are you open to also allowing nurses to come from other states? I just found out that we are the only state that does not allow nurses to come from other states to come and help us. So those are my questions for Toby and Carrie.
Toby, okay, Carrie, go ahead.
Oh, no, go ahead. Toby can go first.
Okay.
As to what is going on in assisted livings and how families are kind of reacting to the restrictions, you point to the exact conflict that exists, which is in order to keep the seniors safer, in essence, you have to do some things that make them more isolated. And the trade-off there has been kind of the consistency of, well, we need to prioritize the safety in this scenario because it is the dangers are so devastating in communal settings for seniors. We fully recognize that that makes it really challenging for family members. That's why we tried to do more with the get folks an iPad, do more FaceTiming, do more virtual. We know that's not a substitute for actual physical contact, but we also know there's huge risk to actual physical contact. I think the way that we emerge from this probably in the long run is probably tied to testing. The more we can test folks who are coming in, because as Carrie pointed out, asymptomatic people can actually carry it and transfer it. So just taking their temperature doesn't tell you whether or not they actually carry it. So the more testing we get on the front side, the more we can isolate the folks that might be coming in, that might be positive, that might be spreading it, the sooner we'll get to more visitors. Would be kind of the short answer. The second part is PPE as well, so that when people in those facilities get it, you can isolate and use protective equipment to not transfer it around. I mean, we saw in Washington and some other cases where you have the unfortunate situation where because people brought it in, it goes from person to person to person within that setting, and it just becomes, the whole setting becomes a whole hotspot. We're really trying to avoid that with as much of the upfront measures we've taken.
I don't know if that answered both parts of your question, Senator Gazelka. Did you have any follow-up for Carrie?
Yeah, the issue of allowing nurses, they talked about making sure we have enough nurses available, and Minnesota being the only state that doesn't allow nurses from other states, is that another tool in an emergency that you would support? That typically would come from an executive order from the governor, which means it would end when the crisis is over. But I just wanted to get your sense of that. I was surprised we were the only state that didn't allow that.
Thank you for the question, Senator Gazelka. I think we're open to ensuring that we have licensed healthcare professionals access and getting them on board as quickly as we can. We know that there's probably an ongoing dialogue with our union friends on that particular issue, but know that in this public health emergency, streamlining and being able to have access to the trained professionals that we need as quickly as possible is vitally important.
Thank you.
Thank you. Senator Rosen has a question.
Thank you, Senator Housley. Hi, Toby. Hi, Carrie. Two questions. Could you put a priority list of the things that are mandatory for you right now? Whether it is the, some assistance with the PPE or the over-the-border assistance from healthcare workers, whatever it is, we'd like to know what your priorities are. And my question is on this Medicare funding and the procedures that are not happening. What kind of procedures and what can we do to help you with that? Is there anything we can do? It's federal, but and what are you going to have a number eventually of how much it's costing the industry?
So I don't know who you want to go.
Yes, go ahead, Carrie.
I'll do the first one, Carrie, you do the second one.
Sure.
Yes, we'll get you a list.
That's cheating.
In priority order.
Thanks, Toby. Senator Rosen, as to the second question, I think at this time, we're not sure that there's much in terms of legislative action we can do. We know there are good reasons why there are stoppage of elective procedures. We understand that. The point of bringing up the impact on providers is we know that the hospitals are losing revenue. Long-term care providers are also, and there is probably a conversation after the fact to sort of try to model and understand the exact financial impact on providers so that we have a sustainable senior care network going forward. We are working with some of our business partners throughout the state to try to model what that lost revenue looks like for providers. So we are working on that. Anecdotally, I just came from my board meeting and some providers shared the amount that they are losing, and it is significant. So it is a long way of saying that the financial strain on senior care providers will last long beyond this public health emergency, and probably it will be a future discussion for us as we better understand those impacts.
Thank you, Carrie. Senator Rosen, is that it? Okay. All right. Seeing no further questions, nobody else has their hand raised. Thank you so much, Toby and Carrie, for your presentation. Stick around, though, in case something else comes up, okay? Next up, we've got Cheryl Hennon, the State Ombudsman for Long-Term Care. Welcome, Cheryl.
Good morning, Senator Housley, Senator Gazelka, Senator Housley, committee members. I sincerely thank you for allowing me time to speak this morning. I am the State Long-Term Care Ombudsman. I have served in the Ombudsman Office since 2004. The Older Americans Act provides the authority for us to be advocates at the bedside of our important residents in living in long-term care facilities. And I need to say to you that at no other time than the present do I recognize the importance of the investment made in building relationships of trust and integrity. I am very grateful for the joint opportunities. We are living unprecedented times that call for unprecedented measures reflective of putting people front and center in all that we do. The impact of COVID-19 on vulnerable adults is a tragedy. To date, families in Minnesota have lost loved ones to the virus, and my heart goes out to all the families and friends grieving their loss. Elders are at a higher risk, and they now face double consequences, including increased social isolation, from strict restrictions placed on receiving visitors. On March 17th, I made the decision to discontinue in-person regional ombudsman and volunteer visits in long-term care facilities to do our part in reducing the spread of the COVID-19 virus. All staff of the Ombudsman Office for Long-Term Care are working daily by virtual visitation, such as telephone, email, or other electronic communications. And this is consistent with direction from the Ombudsman's Office at the federal level and the deployment of Ombudsman staff around the country. And I will tell you, this decision to modify advocacy services delivered from me was not made lightly. Residents still have the right to access the Ombudsman program. We are a statewide program, and we continue to respond to and investigate complaints brought forward by residents, family members, and others. And we are working long hours. Last week, I submitted a status report to my governing board, which is the Minnesota Board on Aging. So to give you some scale of this, I reported that from March 9th through the 20th, we received an excess of 235 new calls, new intakes. The week of March 23rd through March 31st, an excess of over 750 new intakes, calls, activities. And the footnote to this is that the totals are in reality higher than reflected because I instruct staff and they are doing a fantastic job prioritizing direct service to resolve problems. Therefore, best efforts are made to record our data daily. We note a slight increase of complaint work in skilled nursing homes over assisted living. However, we need to acknowledge an intersection between both in terms of work on continuing care campuses, i.e. couples separated. One lives on the skilled side, the other in assisted living, and people are isolated due to such things as restricted communal dining. So I want to give you a few examples of what are the complaints, what are the real life examples, the work that we are doing. A call from a resident reports she is in quarantine in her room. She's in need of personal items. The staff are unhelpful. She is nearly out of toilet paper. She is not getting enough food. She has an appointment to renew her lease, but is being told she can't. She needs a can opener. If she had one, she could better manage with the food in her own room. Another daughter very concerned that the workers at the facility are not wearing protective personal equipment such as face masks. Her mother is on hospice and staff continue to bathe, dress, assist without face masks. A family member calling saying their loved one was recently issued a notice in writing of facility intent to have their mother vacate at the end of the month. And then further concern that if a resident needs to be sent to the hospital due to COVID-19 restrictions, he or she will not be able to be readmitted. And then there are certain problems that are universal and received on a regular basis. Electronic monitoring. Electronic monitoring is law and right in Minnesota. In spite of resident right and law in Minnesota, we are receiving complex complaint reports from people denied the right to place an electric monitoring device. A woman with late-stage dementia on hospice was denied the ability to install an electronic monitoring device. Per the family, the device would take a very short time to install, 5 minutes or less. And the reasoning for installation of the camera is they said, quote, we would like the camera in order to have some insight into what is happening with mom while we have no outside eyes on her and because the phone is regularly not answered. I want to say that I applaud the collaborative effort between myself, the provider organizations, and the Department of Health. On March 25th, the Minnesota Department of Health issued guidance entitled Visitation Restriction Guidance for Residential Care Facilities in Minnesota. This information enforces and reminds providers of the right to place a camera. Of course, people placing the camera must pass a screening requirement and agree to limit their building access to the loved one's room. They also must have proper consent in place. I'm pleased to report success stories, providers actually assisting in installing the device successfully. We have had some family members call to tell us positive stories that this has happened. Within less than 10 minutes, the camera has been installed. We also know that certain federal action has contributed to an increase in our work. And it's been mentioned before, guidance issued by CMS waived many different nursing home regulations, and assisted living facilities, while state regulated, are taking similar precautions. We are receiving many serious concerns from residents and family members about the inability to visit at a critical time. And we've talked about this, I've heard about this earlier in the conversation. The definition of compassion care is vague and should include visits for people at a minimum on hospice. Allow me to share an example. A family member called in tears reporting their mother died the day before. The resident was on hospice. The family called the facility to request a compassion care visit, but that was denied. The facility called to inform the family member the resident had passed. The family member asked to view before the body was sent for cremation. This was denied. The resident's body was cremated and the family was not able to see their parent at all pre-cremation. Safety precautions can be implemented to allow such visits. But I can report a success story. A story of a woman, 107 years old, on hospice, was initially refused compassion care visits by her sons. My staff member spoke with the resident via phone. She was crying and she was yelling out for her sons' names. Numerous respectful communications between my staff member and the provider were unsuccessful. The family filed a report with the Minnesota Department of Health. I stepped in, consulted with the Minnesota Department of Health, talked with the staff, and we were able to make the visit happen. I do understand this is a balance. It is critical to protect residents from COVID-19 at this time. However, there are concerns related to resident safety and welfare beyond COVID-19 that must also be considered. This past winter, for example, our office worked with a resident who was isolated during a flu outbreak in a facility and attempted suicide. Staff reported they believed that the isolation experience was a factor in the suicide attempt. I'll finally touch on transfer discharge. Our office is receiving numerous concerns in this area. And as mentioned, CMS issued numerous broad waivers of requirements for skilled nursing facilities on March 31st. Based on real-life concerns from Minnesota citizens, I offer the following recommendations. My plea is to have all of us seriously consider the following on behalf of residents. The waivers include portions of transfer and discharge regulations in certain situations. I will not go through all of them. Here are my recommendations. It is critical that if a resident is moved from a facility, they should have the ability to return. If a resident is asymptomatic, they should be readmitted to their facility if they can't be safely quarantined for a number of days, even if the facility is not accepting new admissions. If a resident is symptomatic or diagnosed with COVID-19, the resident should still eventually be readmitted to their home. Their bed, their unit, their apartment should be held until the time that the resident can safely return. When considering how transfers are accomplished, residents, particularly those diagnosed with dementia, may be subject to significant transfer trauma. People in secure dementia care units should be considered some of the last to be moved because of their particular sensitivity to moves and transfer trauma. If relocation is necessary, any relocation cannot be solely for facility convenience, but reflect person-centered planning measures. Any guidance should specifically note that an individual may not be selected for a transfer or move for a reason prohibited by law, such as retaliation. If residents are temporarily relocated from apartments, planning needs to reflect proper protection of personal belongings and consider costs that may be involved. Residents need to be assured they will return to their home. Any residents being moved, transferred, etc., pursuant to any new provisions that may be implemented by the Department of Health, by CMS, should be given the contact information of the Office of Ombudsman for Long-Term Care by their provider before these moves occur. If a facility is providing any widespread moves, the facility should notify our office prior to implementing these moves. Any planned transfers moves should be promptly communicated to the resident's family or legal representatives before any such transfers occur. I appreciate Governor Walz's action to place moratorium on evictions. I advocate for a moratorium on service terminations in assisted livings with minimal exception for safety reasons to protect individuals and others. Relatedly, people should not be discharged from nursing homes at this time for reasons such as non-payment, and again, with minimal exception for safety reasons to protect individuals and others. In closing, I end with where my message began. We are all in this together. We must continue to work collaboratively, be transparent, and instill hope. I've talked to many people, and fear permeates our state right now. But this too shall pass. Let's work to be proud of our results. In years to come, people will read about this time in our history. Minnesota results need to positively reflect Minnesota's value and commitment to quality of life and quality of care. Thank you.
Thank you so much, Ms. Hennon. I can't imagine what you guys are going through over there at the Ombudsman office and all of the calls that you're taking. And I know I've referred some people to you, and you've helped them along the way. So I'm so grateful that we have you and all of the ombudsmen that are working for all of Minnesota. We do have a hard stop at 12:25, and we still have Chris Erisman, the Director of Infectious Diseases at the Minnesota Department of Health. So members, if you have any questions, just keep that in mind. But I don't see any hands up. So Cheryl, if you want to stick around and if there's time at the end and anybody has any questions, we'll send them your way. And
I will do so. Thank you.
All right. Thanks, Ms. Hennon. Chris Erisman, Director of Infectious Disease at the Minnesota Department of Health. You are up next. Go ahead.
Thank you. My name is Chris Erisman, and I'm the Director for Infectious Disease here at the Minnesota Department of Health. And I thank you for the opportunity to talk to you about what we're doing related to COVID-19 and long-term care in Minnesota. I do want to clarify that when I use the term long-term care, I'm including nursing homes, assisted living, and other residential settings with high-risk residents. Residents of long-term care facilities are at very high risk of severe disease due to COVID-19 because of older age and medical conditions, and high risk of exposure if the virus is introduced into the facility because of congregate living conditions. I would like to provide some background on the work we've been doing with these facilities before we started to see cases and now that we have seen cases. The Department of Health has initiated a multi-division long-term care coordination work group that includes representation from health regulation, healthcare-associated infections and infection control, infectious disease surveillance, and emergency preparedness. We are coordinating our efforts to respond to COVID-19 in this high-risk population. Since March 4th, we've been having weekly calls with long-term care facilities and provider organizations to relay up-to-date information about the outbreak and any changing guidance from MDH or CDC. This guidance includes updated guidance from the Health Regulation Division on visitation restrictions, infection prevention, etc. Our most recent call was attended by almost 1,500 participants. We also have thrice weekly calls with leading age care providers and more recently the Home Care Association. As of today, we have 65 long-term care facilities with cases. 44 facilities have a single case, 9 have 2 cases, and 12 have more than 2 cases. And I want to be clear that our definition of an outbreak is a single case in a residence, in a staff person, or in a contractor. We now have 103 resident cases and 38 healthcare worker cases. And we have 16 facilities with resident deaths for a total of 20 of our deaths occurring in residents of long-term care. Upon notification of a confirmed COVID-19 case in a long-term care setting, we initiate a comprehensive investigation. Steps include having an initial call with administrators and clinical staff of the facility and representatives from our surveillance, infection prevention, and healthcare worker exposure groups. We work to identify exposed residents, staff, and healthcare personnel and make appropriate testing, isolation, and/or quarantine recommendations. We've developed guidelines for resident contact tracing and exposure risk assessment. Conducting an exposure risk assessment for healthcare personnel and for residents is based on CDC guidelines. We perform extensive case interviews and contact tracing to identify any additional exposures to contacts outside the facility. We also discuss existing outbreak control measures as appropriate. We assess the facility's personal protective equipment, their staffing, and other resources. And we try to provide tailored optimization strategies for scarce resources. We offer a virtual facility infection control assessment by our infection prevention team. So they will work with the staff of the facility to identify any potential gaps and provide them with best practices. We've provided tools and guidance for healthcare worker monitoring and resident monitoring. And we've provided communication materials for residents, families, and staff, including notification letters and talking points. A nurse case manager is assigned to each facility and is in daily contact, sometimes multiple times a day. This individual can help expedite PPE requests and address infection prevention questions or other issues the facility is facing. Personal protective equipment is a huge issue, as you've heard, and we have worked with the State Emergency Operations Center to get personal protective equipment to facilities with cases. The challenge is that a facility needs to have a case before we can facilitate getting them personal protective equipment. The current disbursement is 205 surgical masks and 150 face shields for 1 week. And we recognize that this is insufficient, and in fact, we're at a point where we do not have any surgical masks available anymore. We would like staff to be wearing surgical masks in advance of a case being identified as a means to reduce any likelihood of disease transmission. This is referred to as source control. Evidence suggests that COVID-19 transmission has occurred by mildly symptomatic or asymptomatic individuals prior to being diagnosed. And source control can help to address this, and it can be applied to healthcare personnel, staff, and patients. So we are working with the State Emergency Operations Center on alternative face masks that could be used as source control. They have ordered these masks for use by long-term care facilities, and we are awaiting their arrival. We do have guidance on these alternative face masks on our website. Our biggest challenge, as I said, remains the lack of PPE for facilities. And we recognize that this is a huge problem. So I just want to comment about the family member who called expressing concern that staff were not wearing PPE. In most cases, this is because PPE is simply not available. Staffing is another critical issue that facilities face, and you've heard about this. But many do not have the necessary surge capacity when staff need to be furloughed due to exposures and quarantine. And facilities are faced with critical staffing shortages. And this is a concern because we're providing these facilities with guidance on steps they need to take. And if they don't have adequate staffing, they're unable to follow through on that guidance. This has been compounded by our recent decision to post facility names. The decision to list names of facilities with cases was a difficult one. However, providing the names has had a number of unintended consequences. Staff have resigned over the posting, with one facility losing 7 staff in 4 hours. Facilities are also disincentivized to test residents of staff for COVID, since it will mean being listed on what they perceive as a wall of shame. So this is a concern for us. We've received questions about whether or not a facility who offers to take an individual who's been in acute care with COVID-19 into their facility and has adequate space, PPE, et cetera, if this means that they would be included on the list on our website. And there's concern about that. So we are continuing conversations about those things. In summary, we're working closely with long-term care facilities both to prepare for potential cases and to respond when a case is identified. However, these providers face multiple challenges as they struggle to respond to COVID-19 in their facilities. Thank you, and I'd be happy to take questions.
Thank you, Ms. Erzman. We do have a question from Senator Benson. Senator Benson?
Hi, good morning. And first of all, thank you, Chris, for everything you've been doing for more than a month now. I don't know how many people realize how long ahead of this your team actually started working. So thank you very much. With regard to the names that are published, when the folks in those facilities have finished their quarantine, are the names taken off the list?
We've been having conversations about that. And there's two schools of thought, and we're really struggling because we don't want this list to be a wall of shame. And I've been very clear in our media conversations to explain that, this is a very complicated situation, and it would be wrong to assume that facilities that have a case are somehow deficient. But what we're struggling with is we could take facilities off once they've gone past a certain point with no new cases. But the question is, if we take them off, then is that a disincentive for them to continue to identify cases? Is it better to just be stuck on this list perpetually, or should we modify it? So that's something that we're honestly struggling with because of how the list is perceived. But we want to do what's right by facilities, and we certainly don't want them to be perceived as not providing the best care that they can.
And thank you. And Senator Housley, if I could continue, thank you, Chris, for the balance there. I am disappointed that facilities think of it as a wall of shame. If you've got 350 beds and you have a couple of cases pop up, you're in a high-risk population. I think making that information available to families helps those families understand what's going on, takes away the sort of black box feeling that some families are perceiving about their long-term care facilities. I wish there was a list of really great things that the care systems are doing, but that's not where we're at right now. With regard to the types of masks, so I've had a couple of contacts with long-term care providers, and are they clear that the non-N95 masks can be used as a level of protection? Because N95 masks are very high level protection. And yes, it's important in a high viral load or in a virus contact environment, but are you helping them differentiate between when a face covering versus an N95 mask and all the levels of shielding and personal protective equipment are between the no coverage and masks and shields level?
Thank you, Senator Benson. Yes, we are working to provide that information to facilities. I think the challenge is that while surgical masks would be ideal in many, many of the situations, we are out of surgical masks at this point. So that's been the challenge, you know, is do we now move to provide N95 masks just simply because it's what we have available? Our goal is that we will be able to make these cloth alternative masks available, and so they could be used as the source control. It doesn't protect the wearer like personal protective equipment does, but it will reduce kind of an extra step to try and reduce the potential for transmission from that individual to someone else. So those are the things that we're working with the facilities on. And as I said, we do have a team that you know, reaches out to them and kind of goes through what's happening in their facility. But the absence of personal protective equipment is a huge challenge, and it's across the healthcare system, but we feel it most acutely in our congregate care settings because they have the absolute most vulnerable population, and we're seeing the devastating effects of transmission.
And if I could, Senator Housley, just to follow up, are you giving them guidance even if they don't have a case? Because I've talked to one manager, nurse manager, and she didn't feel like she was clear that she could tell her staff that cloth masks they made at home were okay. And so have you provided sort of preemptive guidance even if they don't have a case?
Yes, we're trying to do that. And I mentioned we have the weekly calls with these facilities, as well as we've put out sort of checklists and guidance for them. But certainly if that's a question, since we're in the process of trying to get those masks for them right now, I'll make sure that on the call this week that we clarify that is an accepted manner of source control.
Okay, thank you very much. Thank you, Senator Housley.
Thank you, Senator Benson, and thank you, Ms. Erzman. Does anybody have any other questions for anybody that's been on this panel? There's no hands up, so we do have a, yeah, go ahead.
Yeah, I don't have a question, but I wanted to make a comment. A couple of things that came up on some of the other presenters that I wanted to address. One is that the department has established a waiver related to TB testing so that the baseline TB test can be administered up to 90 days after the date of hire to help address some of the challenges related to getting staff in and not being completely tied up with requirements. It is still a very important thing. We have a multi-drug resistant TB outbreak that's going on in the background, but we have made some modifications there. So I wanted to address that. And then the other thing I wanted to mention was just that we have prioritized testing of congregate care settings, so long-term care settings, residents, staff, as our #1 priority, and that is the only test right now that the Department of Health lab is taking because we want to make sure that we have the capacity to do the necessary testing. But what we're hearing from partners and through our provider line and things is that when staff go to see a healthcare provider, oftentimes they're unwilling to test. We've deployed swabs and kits out into the field, and we're trying to make those more available to our partners in long-term care so that they have what they need to do testing. And then, as I said, our lab will do that. But obviously testing has been a huge challenge across the system, but we're doing what we can to make that more accessible to our partners in long-term care. That's I think all the things I wanted to respond to, but thank you.
Thank you, Ms. Erzman. We have a hard stop here at 12:20 for Gazelka, Senator Gazelka's. Senator Pratt, you did have your hand up, but then you took it down. So did you still want to ask a question, or are you good to go?
No, I guess I can ask it still. I mean, I was on at the governor's dashboard, and it looks like we've got, some inventory. I'm just asking, not to be critical of the administration. They're doing the best they can, but tell me about how it is to get some of that inventory distributed to your facilities. Are you finding that you're having a hard time competing with hospitals that are dealing with current cases? Any thoughts on what we could do legislatively maybe to help?
I'm not sure. I can tell you one thing that we're doing here at the department is that there is a system that we can use to get PPE through our warehouse, and so we have our case managers working with facilities to expedite that and to help them do the necessary paperwork to get that through. But so we've tried to facilitate as much as possible, but we're having difficulty obtaining PPE. So I can answer that from the agency side. Thank you.
So it's not a logistics problem. It's a supply problem. And maybe not being a health professional, while the numbers, look in the thousands and look to be fairly large, maybe that's, that's still a shortage, it sounds like.
Yes, we're still facing some challenges with that.
Okay, it's just putting it in context. Thank you.
Thank you, Senator Pratt. Any other members have any questions? Okay, that being said, I want to thank everybody for participating in this working group focusing on long-term care. It's good to be updated. Keep doing what you're doing. You're doing a great job, as best as we all can do. I want to turn it over to Chair Gazelka to wrap this up.
Well, thank you, Senator Housley. Great job moderating. This is really at the front lines of the people that are most at risk from COVID-19. So I'm really glad we took the time to focus it today on that. And a couple of takeaways that I took is just a reminder that as much as possible to be flexible with some of the rules that we have to streamline and get things done and quicker is one of the takeaways I heard from more than one person, that we should in any way possible try to prioritize testing. The part I always knew was that would help the workforce stay in place. But another part of it that I took away from this one is it then gives us the ability to perhaps reduce isolation quicker just because we know what's going on. So that was a takeaway that I took. And another one that stood out to me was to make common sense exceptions to see seniors at particular moments so that the family can connect in those key moments, or in ways that we can help seniors. So to not be afraid to have some exceptions when there is isolation in place. But very helpful for me. We'll continue to listen to the people that are right on the front lines for this. So thank you for everyone that testified. So one more thing, as far as for tomorrow, we're going to do another one of these hearings. It'll be at 10:30. It's going to talk about the continuity of transportation operations and how those are affected by COVID-19. So that's what we're going to address tomorrow. We're going to be on the floor today. So you guys, anybody that's watching here can watch the House on the floor. I believe it's noon, and we're at 2, somewhere in there. I think that's about what it is. So, but thank you for listening, and we'll see some of you tomorrow. With that, we're done.
Bye. Thanks, guys.